we'll kick off now then. Right, welcome everybody. Thanks for joining us for the All-Ireland ITP support group meeting for July. With us today, we've got our ITP medical advisor, Dr. Gerard Crotty from the Midland Regional Hospital in Ireland. We've also got senior patient advisor, Rhonda Anderson, medical advisor, I should say, and the vice chairman of the ITP Support Association, Derek Elston. Unfortunately, you know, we've only got a couple of patients, but we did have 10 sign up today, so hopefully, we'll have some good questions. I've actually got a question from Elizabeth, who's with us now. Would you like me to read it out for you, Elizabeth? Okay.
Please,
right.
Mervyn, yeah.
Yeah, will do. And I did send this across to Gerard earlier. Is it possible, if it's possible, I would like an opinion on whether it would be recommended that I take rituximab. I've just celebrated my 70th birthday, and you don't look 70, Elizabeth. And I've had ITP since 2013.
Thank you.
Treated with steroids and IVIG plus steroids in 2013, 2014 and 2015, then 5 years remission. IT back again since last September. IVIG plus steroids did not work, so Eltrombopag was added to her treatments. Her platelet count increased, but she developed a serious rash, so it was abandoned. The rash took 4 months to resolve and was very similar in looking at to herpes. I have received IVIG monthly since. My platelet increased during this time of me getting COVID. It went back, then when she had COVID, it went back down to 50. Now a hematologist is recommending she goes on rituximab. She's not sure. Now, I did also send Gerard a couple of pictures that Elizabeth sent of some of the rashes.
Thank you. I'm sorry, Mervyn, I seem to be very unfortunate that I have very bad reactions.
It is very rare, you know, from what I know, it's very, very rare, you know, what you had. Gerard?
Yeah, I would agree. It's not something I've seen in terms of a rash to Eltrombopag, but any drug can cause a rash, and, you know, it certainly seems to be quite a severe rash. So if there wasn't any other likely culprit, then I think it definitely would be best to avoid that drug in the future. And, you know, you probably might be a bit reluctant, unless you had no other choice, you're probably a bit reluctant to use another drug very closely related to it. So, for instance, you may have access to Eytrombopag, which is another drug very like Eltrombopag. But again, you know, when we use two drugs that are very, very similar, sometimes side effects like rash may occur again, sometimes they don't. But with other drugs, there's really no particular reason to believe, say, that similar side effects would occur with rituximab. Side effects with rituximab can occur. And, you know, I think in terms of the immediate choice of treatments, obviously I haven't seen your level of symptoms and your trend in your counts. But if the platelet count's 50, one option is to temporize, postpone the decision for a while, because if the platelet count remains at that level, that is a safe level. And for many patients with chronic ITP, if they don't have symptoms and they're not on anticoagulant drugs, you know, we would be happy with a platelet count over 30 in many cases. And so there is a bit of leeway there just to postpone a decision. But it does seem quite possible or likely that, you know, given that one of the second line treatments, Eltrombopag, had to be abandoned, that maybe another second line treatment might need to be used. And there's a choice there. One choice is romiplastim, which is has a higher response rate. I mean, it has a similar high response rate to Eltrombopag, whereby you know, the very significant majority of patients will respond. And it works in a similar way, but it's not actually chemically related to Eltrombopag. It's given in a totally different way. It's given by an injection once a week. So that could be a very good option, particularly if Eltrombopag worked, but then had to be stopped because of side effects, because romiplastim is not chemically related. So it is unlikely to cause a similar side effect. So that would be one option. rituximab is the other one we tend to turn to. Response rates with rituximab are a bit lower. I mean, they're probably no higher than 50%. And then in the long run, of course, it's given a different way. With the TPO-RAs, with ramiplastim, you'd keep taking it. You'd keep getting it every week with the dose adjusted as needs be, probably for a couple of years, and maybe ultimately it could stop, or maybe it would continue indefinitely. But with rituximab, it's generally 4 doses, and you hope to get a prolonged response, but not everyone does. So even of the maybe 50% who respond, probably half of them will relapse relatively quickly, and so you probably only have 25% prolonged response rate. So you will get a higher response, prolonged response rate. Again, it's an average, and it's different people do differently. So I think rituximab is one option, ramiplastim another. If the platelet count is remaining at 50 without symptoms, then doing nothing for the time being is another option. They would be my thoughts from what you've said.
Lovely, thank you. That's more or less what my hematologist has said, that I think to see how far will I go, what's my baseline, and to work from there. But I'm very afraid of rituximab. My rash was so, and they've ruled out Eltrombopag as well. So. Yeah.
I mean, there are other choices, so I think there's no need to be using a drug that's very similar to the one that caused a severe reaction.
Yeah, it's just, sorry, one last question. It's just that I'm very I have very bad stomach problems, and I'm just kind of very unwell otherwise. I'm just afraid of the rituximab. That's it.
Yeah, well, again, I mean, if necessary, that might need investigation in its own right, a gastroscopy or whatever. I mean, it could be thought about. I mean, rituximab. The other thing about rituximab does suppress the immune system. It does reduce antibody levels in terms of antibodies against infections, including COVID. So it probably does increase your risk of getting COVID. You probably still have some immunity from your T cells that might prevent you getting severe disease if you got COVID. I have no idea if you got COVID already.
Yeah, I have.
But you can always get it again, and if you're on immunosuppressive.
My platelets went up to 250, but went back down to 40 then.
Okay, interesting. But it's just that it is a general consideration at the moment. Any of the immunosuppressive agents, but particularly rituximab, we think it does, more than other treatments, increase the susceptibility to COVID and other infections.
Thank you.
Unfortunately, COVID has not gone away. It's still extremely numerous cases at the moment again.
Thank you.
Yeah. Elizabeth, may I ask you a couple of questions, please? You were saying that your platelet count is around 40 or 50. Is that usual?
Well, I don't know what is usual, because I'm getting IVIG every month. So it's going back down to like 60, 50, but it went back down to 40 from the 250 with the COVID the last. So I think they're going to wait again maybe and see. I think I have a couple of months before I have to take, before I have a couple of months grace to.
Yeah, and the other thing I wanted to ask you was, do you have any troublesome symptoms?
Not really, no, just tiredness, just very tired in the morning.
Yeah, because the thing is that sometimes our doctors say that if your platelet count isn't very low, say, 10 or under, and you're not actually getting symptoms, then one of the things you can consider is what Gerard said, which is, doing nothing. Well, you've got your IVIG, so you could continue that and see how you go. Because if your platelet count isn't very low and you're not getting any symptoms, then you really need to sort of think about whether you really want any intervention.
That's right. Yeah, they have said that they're going to see how. I've gone to 0. I mean, I've had to get 3 units of blood there before Christmas because I didn't realize that I was gone so bad, because I had surgery on my stomach. So you know, I do go down to 0. So, you know, it's very, and then I start from scratch again. So,
I know Derek, who's with us on the call. Derek, like, you know, perhaps you could just enlighten us, because I know your count was about 15 for a number of years with no intervention.
My count was 10 for 10 years or thereabouts, with no medication. I bruised initially, and then I stopped bruising, but I was very fortunate. I didn't bleed, apart from once.
yeah.
I had a bad bleed, but I'm very lucky. And if you're dropping down to 0 with lack of medication, then difficult choice, Elizabeth.
Thank you. It's yeah. So thanks. I appreciate all your suggestions.
Thank you very much, Elizabeth. Thank you. Right, I've got another question, Gerard, that's come in, and it's coming in the last week. It's come in a couple of times from different people, and it's one that I've never thought of. But people with ITP, you know, this trend at the moment for having your eyebrows tattooed, that a lot of people do. Is there a risk if someone's got ITP? That's a question a bit out the box, mate. So
it is. I don't know. I don't think it's a very invasive procedure. I mean, obviously, it would depend on the platelet count. If there are needles involved, which I presume there are, and your platelet count is below 20, then there would be a risk of bruising. That's really all I can say. I know about the procedure and how invasive it is. Yeah, but it would be better. You know, many small procedures, like say a simple dental extraction, can happen with a platelet count below 50. We used to say 50 was the cutoff for procedures, and certainly that is definitely the case for major procedures, and indeed for certain procedures or for spinal anesthetics, a much higher level of probably 80, 75 or 80 is required. But for small procedures under local anesthetic, or, you know, like a simple dental extraction, an easy tooth as opposed to a wisdom tooth, they often don't need the platelet count brought up to, you know, 20 or 30 would be fine with local measures. So, you know, probably something similar will work with that, but you're probably better to choose a time when the platelets are not below 20 anyway, because that's likely to increase the risk of bruising.
Yeah. Okay, I shall pass that on. Thank you very much. Right. Bonnie, I know you had a question, but you didn't really want me to read it all out. But I've had a similar question in from someone else about the same subject.
Okay, go for it. Go for it.
Right. So what it is, Gerard, ferritin levels, and you know, Bonnie, like, would you like to explain?
Yeah, of course, absolutely. So I've had ITP since 2016. I've had all sorts. I've had steroids. I've had rituximab. I had N-plate, and now Eltrombopag, and then I went back to Eltrombopag as a result of COVID, and that I'm still sort of hovering around 30 or 40 on 75 milligrams a day. But I don't really mind having that platelet count. I just cannot manage the fatigue. I like, it just gets worse and worse and worse and worse. And last year I pushed to look at my iron, and I had a ferritin. My hemoglobin is always fine. It's always about 148. But my ferritin was 16, always 16. And so they said, oh, that's fine because it's not below 13. And I was like, well, blooming heck, that's fairly low though, bearing in mind it's quite close to 13. So I initially got given iron tablets, which completely messed with the Eltrombopag, and my platelets went to the floor. So I came off the tablets, and then my ferritin went to 6. And my GP said, you can't do that. You have to actually have some sort of iron therapy. So I got given an iron infusion, 1 gram of iron, and it changed my life completely. And I had, up until that point, up until last year, I blamed all my exhaustion on my platelet count. And then I realized when I had an iron infusion that I felt more like myself than I'd ever felt for the last 6 years. And anyway, so my ferritin went from 6 to, and that was in August, to 101 in December. And that 6 months was the best 6 months I've had in years and years and years. And then in March, I started to kind of feel really rough again. I was like, what's happening? And so I had my ferritin tested and it was 43. So it dropped from 101 in December to 43 in March. So I said to my consultant, I think we need to keep an eye on this because obviously the trajectory is going down. Anyway, 2 months later, I went down to 19 and I said, can we start thinking about an infusion? And they're tentative because my hemoglobin is so good. So I then spoke to an iron specialist and I got an appointment at the iron clinic in Oxford. Went up there because part of my consultant was saying, well, I deal with your platelets and not your iron. And I was like, well, I really want someone to treat all of me because I am literally the whole package. And it's quite difficult to keep getting put over there for the gastro and over there for gynae and over there for platelets and over there for iron. And I thought, okay, I'll go with this. So I went to an iron clinic and by that point, my ferritin was 9. And that was only like 3 weeks later. So I was completely right about my trajectory going down because I was starting to not be able to get out of bed again. And I knew this was awful. So I went there and they said, yeah, obviously we need to give you an infusion. But what they wanted to do was give me half. They wanted to give me 500 milligrams and then in 3 months go back and have the other 500. And I was like, yeah, that's fine. So I had that done 2 weeks ago. Instantly, like within 2 weeks, I was able to get out of bed and kind of go, okay, I'm feeling good. And the idea is that I go back in 3 months and have a top up. But now Oxford University have said that I'm out of area because I live in Surrey and I can't go back for a top up. So I'm stuck now knowing that that is the answer to my extreme fatigue, but trying to get a practitioner or a consultant to treat ferritin when your hemoglobin is normal is a nightmare.
Yeah. It's a difficult question. And look, paradoxically, I mean, certainly, maybe Oxford is different or UK is different to Ireland, but certainly where I work, the ITP expert and the iron expert are the same person. They're both me. So I wouldn't be there wouldn't be any iron expert anyone could go to that's any different to the person who's treating their ITP. And we do give a good deal of IV iron to various groups, people who have iron deficiency, anemia that doesn't respond to oral iron, a small number of people who have ongoing hemorrhage, ongoing bleeding that need more iron than you could possibly take orally for various conditions, and pregnant ladies who need their iron brought up quickly. And we would give it to it's only an occasional problem with ITP patients, but because our ITP patients attend us for review of their ITP, it would be relatively easy for us to fit them in for IV iron if we so decided. Now, one of the issues, and the number of ITP patients is relatively small, so it wouldn't be a big problem for those. But I think hematologists in general are probably a little bit reluctant to start advertising, please send all your patients in the county who have a normal hemoglobin but have a low ferritin to me, because there would be more patients with that early stage of iron deficiency and maybe a bit of tiredness than could possibly be seen in all the hematology clinics in the county put together if they did nothing else. So there is a kind of a resource issue there that, if someone has severe iron deficiency anemia, they'll get to see someone, and if they're not responding quickly to oral iron, we'll get them up to the day ward, we'll get them IV iron. If they have very mild anemia, we'll try them with oral iron and we'll hope it works. And if it doesn't work, we'll say, okay, we'll bring in, it didn't work, we'll bring in and give you IV iron. But, it is, just the number of potential forgetting altogether about ITP, if we just said, please send me all your people who have a normal hemoglobin but have slightly low ferritin, I would need to employ we'd have to have about 5 more hematologists just to see those people, because it's a very common condition, particularly in women due to menstrual periods. A degree of iron deficiency or a latent iron deficiency, which is what you call that, where the ferritin is low but the hemoglobin is normal, would be extremely common. The IV iron rush does work very well. We usually, I rarely give any less than 1,000 for my first dose. I do a calculation with a little formula called the Ganzoni formula, and you can find it online. You put in the weight of the person and their hemoglobin, and it'll tell you how many milligrams is their deficit. And if it says 1,500-ish, we give we give a dose of 1,000 and we bring them back a week later for a second dose of 500. But most, in general, just doing the calculation in my head, if you're not anemic, if your hemoglobin is normal, from me, you would get 1,000 if you need it, you know.
Yeah, that's what I had originally, and it was amazing.
Yeah, and it is amazing, and it can work. I mean, again, people vary. Some people have tiredness for other reasons, and they don't feel any better after you give it. But people do often feel better and have more energy. The other
so when
thing,
you
though,
say slightly low, what would you say a low ferritin is? Would you say below 30 you would treat?
Yeah. Well, if you're anemic and you're even though most labs, the normal range would be something around 11, 12, 13, 15, up to 300, all right?
Yeah.
And I often get letters from doctors saying, this person's anemic, but it can't be iron deficient because their ferritin is normal as 20. Well, if it's less than 30 and you're anemic, it's iron deficiency anemia.
Yeah.
But, you know, if your hemoglobin is normal, it's still low iron stores if your ferritin is 13. You know, the stores are still low, and it can lead to symptoms of tiredness. And there is some literature around, particularly in children, about development and kind of physical and mental development and so on. So there is some evidence that people can have symptoms when they're not anemic. The other angle, though, that can be, one of the, I will see from time to time whether they have ITP or, people just who've referred to my clinic with iron deficiency anemia that is not responding to treatment. In women, it's often the heavy menstrual periods that would be a contributing issue. And obviously ITP is going to make that worse if the platelets are low in many cases. So often you're dealing with a problem that's going to keep coming back. So if we give 1,000 of Ferinject, which is the one we use, patients going to have good iron stores for a few months. But if they're losing more iron every month than they're gaining in their diet or their tablets, then they'll be back to square one 6 months later and back again for the same. But if it's the periods, then we do often suggest that the patient, through their GP or a gynecologist, would have maybe the Mirena intrauterine system or some other treatment to reduce their menstrual losses, because otherwise it's going to just keep coming back.
That's what my iron consultant said, but actually my periods only last 2 days and they're not very heavy at all. So I don't think it's to do with that. I've had all the colonoscopy and endoscopy, and we can't work out why I'm losing so much iron. But interestingly, when I first had my 1,000 of Ferinject, my platelets went up to 101,000 2 weeks later, and I'm generally about 30. Now, I thought that was linked, and obviously because it was only one example, we can't say it's linked. This time I had it, and a week later, my platelets were 85,000. So having an iron infusion, for whatever reason, spikes my platelets for a little while, which also makes me feel good as well. So
I haven't seen that. I haven't seen that happen.
Have you not? It's fascinating. No.
The other thing is that, even if your periods are not heavy, I mean, they did a study many years ago in St. James's Hospital in Dublin. Actually, they got women to wear pads and they extracted the hemoglobin and measured it. And the correlation between how heavy a woman perceives her periods to be and how much blood is actually lost is very poor. So, and also, even without heavy periods, iron deficiency is much more common in women than men. And, so even light periods may still be a contributory factor. Diet is a factor, and so on. Obviously, if you have a vegan diet, you're not going to have as much iron that's easily absorbed, because the iron from animal products is easier absorbed than from vegetable products. So there's a variety of factors there. And
I think what I struggle with is I understand resources, and I understand that 20% of women are iron deficient. But when you're thinking about quality of life and actually feeling okay and feeling good, it's really difficult to accept that when I've just had an iron infusion that changed my life completely. It took me back to sailing. It took me back to all the things I love. And then I lost it all again. And so it's kind of like saying to somebody, you can't have your life. And I find it really tricky it's easy for me to quantify that my life is better and more fulfilled and more nourishing when I'm not in bed all the time. But obviously I understand when a consultant's saying, well, it's resources, lots of women are like this, but I'm not going to go for that. I mean, the fact that other people are like it is sad as well, but.
Yeah. And in your case, you definitely felt a lot better. And you didn't have any reaction to the iron. So I would have no hesitation about giving that to you again if you were my patient and you needed it again. In fact, I get, if you didn't have ITP and you weren't, I get patients, I have patients and they have attended for IV iron and felt better. And then a year later, their GP writes to me and say they're iron deficient again. I just book them into the day ward. I don't even see them. I just tell them.
Yeah, because that's how I feel. I feel like
prescription and we give it.
Yeah.
But because the bottleneck would be putting the patient through the clinic. So it could be helpful maybe if you're out of area and you can't go back to Oxford or wherever. I mean, maybe it's a different system to our one, but you could maybe ask the iron specialist to write a letter to your general hematologist to say that you responded so well that they would recommend it again and see how you get on. That's
absolutely
what I can suggest.
And what I said in terms of resources is that I was going to my ITP clinic every 2 or 3 weeks talking about how awful I felt. And when I had an iron infusion, I didn't see them for months because I felt great. So in terms of resources, I was saving because I just kept going, I feel terrible. And they're like, oh, that's ITP, I feel terrible. So they didn't see me for months.
Yeah. Now, it won't be, for other ITP patients listening, it won't necessarily be the answer to, it's not the answer to all fatigue, no. But definitely if someone is fatigued, iron deficiency with or without anemia is a consideration and should be excluded and could be treated. But a lot of ITP patients have fatigue, which isn't due to iron deficiency. And
of course.
At a previous meeting of this group, I think associated with the conference, there was a discussion about that. And it's a tricky one because treatments for ITP that are tested in trials and are known to put up the platelet count don't necessarily, as far as we know, necessarily treat the fatigue. So it is a difficult area to know what the best way to manage that situation is. Clearly, if the platelet count is low enough to require treatment, then an ITP treatment would be a good idea and might help the fatigue as well. But in some cases, it won't. And, we should look for other causes: iron deficiency, low thyroid function, depression, overwork, lack of sleep, poor sleep hygiene. There are all sorts of reasons why someone might be tired, which may or may not be related to ITP.
Mm-hmm. Thank you so much. That's really helpful.
Right. A few things, Bonnie, if I may add. I would absolutely agree with getting the letter written by your consultant in Oxford to your consultant in Surrey. I would get in touch with Sue Paybod.
That was who it was. That's exactly who told me to go to the clinic. And
Right.
It was her clinic that I went to and was so excited until I was then told that they won't fund an outpatient anymore.
So she's in Oxford.
Yeah.
Okay, right. Well, she is very good on this. So get her to write the letter
Okay.
to your lot. Yeah, okay. So, you could write to her straight away and ask her, explain and ask her that, because she is very keen on this particular issue. The other thing is to get in touch with your CCG, your clinical commissioning group in Surrey, and probably with Sue's letter and with your other, things that you can back it up with, and say to them that you would like this to be funded in your neck of the woods, so that you can have it. So there are all sorts of things that you can do.
How do I go to my CCG direct? Do I have to go through my GP?
No, I don't think you need to. I think what you can do is look it up online. Look up CCG for Surrey, or Surrey, isn't it, that you're in?
Yeah.
Which hospital are you under?
So I'm actually at UCL. I'm at the Macmillan Centre.
Okay. Anyway, if you get it onto the CCG and see if you can maybe email them or phone them to get some advice on how you could ask for this to be funded for you.
Okay, brilliant. Thank you. That's really helpful. Thank you.
Details of the CCGs are available online. So,
Yeah, great. Yeah.
And if you have any trouble getting hold of Sue Pavitt, Bonnie, just let me know, and I'll contact her on your behalf.
Oh, amazing. Thank you.
Okay, great stuff. But just on the, it was mentioned a few times there, the fatigue issue, and Gerard mentioned that we discussed it a lot at our convention. In the last week, I've just published all the videos from the fatigue symposium we run on the Sunday of the convention. So they're now all on our YouTube channel. So if the Q&A session, there's a smashing session by an American lady called Greta Barrows about her life and how she found fatigue. We've got a good talk by Dr. Robert Klassen from Canada, and a fantastic talk by Dr. Adam Suka from Boston. And they're all on there, all focusing on the issue around fatigue. And as Gerard said, many of these medications that people have and people are treated with, they don't always focus on the fatigue bit. And the fatigue can be a myriad of other things as well. It's not always ITP. So just remember that. Okay, right. Bernie, have you got a question? Bernie Smith. You're muted if you're trying to talk to us.
Sorry,
you've got a camera.
Yes.
Can you put a camera on?
You know what? I joined in late. Let me just see. And I didn't like to disturb.
That's
too much.
okay. No.
Where's my camera? There we go.
There you go, Bernie.
Have a go.
I'm looking up. I'm looking down now. Yeah. Sorry. Yeah. Apologies for the late joining. Just one question. I missed the first 10 minutes, so if I'm repeating anything, apologies. I have had ITP for the last 40 years. I got it as a child. I've had a lot of different treatments over the years, predominantly steroids initially, splenectomy. Then later on I had Imuran I had quite a bit of, and then in the last probably 8 odd years I've had IVIG with steroids, and then I've tried the Eltrombopag a few times. And the way I'm very lucky when it comes to my platelets, I'm either rock bottom or I'm 100%. So when it's as if my immune system needs to be rebooted, and when I'm back up, my platelets are fine. So I'm quite lucky. I got my platelets done at my hematology appointment the other day, and there were 304. So as man says, when I'm up, and when I'm down, I'm down. But I was trying to, my hematologist is very great and works with me. And we've tried a couple of different ways of dealing with this in recent times. And the Eltrombopag, it doesn't work, and when my platelets are up, it just puts them up through the roof. So we've decided that's not the way to go anymore. I just wondered about Imuran. I just hear a lot of the Eltrombopag, Avatrombopag, rituximab, and all this. From talking to my hematologist, my preference is to go back to the dexamethasone maybe, and a tapered steroid, and the Imuran, because it seems to be what keeps my immune system before it reboots. I just wonder, I don't hear as much talk about Imuran anymore. Just wonder what Dr. Crotty or Mr. Crotty there, his opinion on it.
Imuran is a trade name for azathioprine. So some people may know it by that name, which is the active ingredient. And it's a very old immunosuppressive drug, and it is quite safe. The response rate wouldn't be as high as, say, Eltrombopag in trials in general. And but it certainly won't produce a very high platelet count above normal, which the likes of Eltrombopag will do at times. I think overall, I have some patients still on it that were on it for a long time, but because we have so many other choices more recently, I haven't put anyone on it recently for ITP. But it does work, and if it has worked in you before, then maybe it would work again. I don't have any particular data on how well it works in people whose spleen has been taken out. you know, the mechanism of action is by suppressing the immune system. You know, it may be worth trying. I mean, you know, if you know it's agreed with you before and not cause side effects at whatever dose, whether it's 50 milligrams twice a day or 3 times a day, I think would be the maximum. You know, it would be potentially worth trying again.
Yeah, I mean, I would usually, as I say, I would have had dexamethasone, you know, for the 4 days, and then started on Imiran 150 milligrams a day, and then I would weaned off the steroids. The platelets would be back up to a normal figure, and then I would wean off the Imiran could be over space of a year, 18 months. But I know I've had quite a few hematologists, obviously, because I'm 40 years at this stage. And I think the preference was obviously the concern about the long-term effects of being on the Imuran, and I think it kind of, I kind of was put in the direction maybe of as I said, the Eltrombopag and that, and it just, I know there was mention of vincristine being used this time. I wasn't on for that, and I'm the one that's advocating because it's worked. I'd say I had 30 years of the combined steroid and Imuran. It worked every time.
Yeah, and I wouldn't be too. I know there are lots of patients who've been on it for years because, of course, over many years before we had other choices, you know, we used it not just for ITP but for autoimmune hepatitis and a whole variety of other conditions. The other thing is if in a similar vein, another drug which, in your case, given that the Imiran azathioprine worked before, it may be worth trying again. But if someone was coming at this afresh, having never had an immunosuppressive tablet, there is a tendency now to use mycophenolate mofetil. I don't know if you've ever had that one. Spellcept would be the most common trade name. And it is another immunosuppressive agent, a somewhat more modern one, and somewhat more expensive one, depending on who's paying for it. But it is covered on the high-tech schemes in Ireland, so you don't have to pay more than a nominal amount for it. So you know, in your case, I think you have a very strong argument for trying something you knew worked before. Someone who has maybe for some reason or other is not suitable for Eltrombopag, Eltrombopag, romiplastim, or rituximab, then you know, one might go more for mycophenolate than azathioprine, but you know, they are still options. Even drugs, we don't use that much nowadays. And I'm old enough to remember it being used much more widely before we had so many other choices.
Yeah, well, it was just more, was there a general movement away from the Imuran is what it was more, you know, because as I said, I joined or listened to a lot of meetings and obviously keep up to date, and I just don't see it mentioned as much, and I just was wondering, was there a kind of a movement away from it?
It's mainly just that there are other drugs with higher response rates, and the other thing is, it isn't. I mean, there's no one, I think, ever done a trial of azathioprine versus none in ITP and published the results and got approval for the drug is not licensed for ITP. Okay. But it's only in recent years that trials have been done with some of the more modern agents, you know. So there are reasons why we've moved away from it, but it still works as well as it used to work, and it's still there as an option, you know, in certain cases.
That's great. Thank you very much.
Thanks very much, Bernie. I hope that helped. Yeah. Good stuff. Gerard, I've just had another question for you. I was just going through my emails, and interesting one. I'm not sure if you can answer, but a lady with chronic ITP, but she also has type 2. She's also a type 2 diabetic, and she's wondering, is it possible that the insulin she takes for her diabetes could be causing the ITP to flare? Have you heard of that at all before?
No, I haven't. I think it would be very unlikely. I mean, it is recombinant insulin. It's very similar to the natural insulin that we all have, that type 1 diabetics are missing, but she's type 2, I think. So presumably she has the more severe form of type 2 diabetes that requires insulin. But obviously the interaction between diabetes and ITP, there would be a number of interactions. High-dose steroids might play havoc with the sugars, and that's something to watch. But no, I'm not aware of any connection between insulin therapy and exacerbating ITP.
Thanks so much, Gerard. Thank you. Okay. Right. Any other questions, anyone? Elizabeth, Bonnie, Bernie?
I'm sorry. Again, well, one question
Go
we'll
on,
ask,
go
and
on,
again,
Bernie.
just is around the vaccinations, boosters, and COVID. I had the AstraZeneca during at the end of or in the middle of an ITP relapse, and my platelets were stable. They were in their 200s, and after the first dose of the AstraZeneca, they went down to 30 or 40. But it was transient. They went back up a couple of days later, and that was fine. I got my second booster. I had no issue. Or my second AstraZeneca, I had no issue. And then I got, I actually got COVID the week I was supposed to get the booster, and that was last December. And I always have had a half concern that my ITP was vaccination related. So I'm not in any way anti-vaccine. I've had loads of vaccinations, but I was kind of reluctant to kind of go back again if I didn't need to. So having had the AstraZeneca and had one bout of COVID, I haven't gone back to get a booster. I just wondered what your opinion, Dr. Crotty, on that is. Well, I know my recommendation is by my hematologist, by the way, is to have it.
I mean, the general recommendation is you should get your booster, and indeed, depending, in your case, post-splenectomy, and particularly if you're receiving steroids regularly, or if you're on azathioprine or other immunosuppressive agents, you would fit into the immunosuppressed category. So if it's more than 4 months since your first booster, you may be eligible for a second booster, and you can get your details passed on to the vaccination centre by your haematology team. I've only just recently discovered that there's a mechanism for sending it on to get you on the list for that. So in general, we would recommend that you get your boosters, and even in patients, I mean, they've studied this in people with lymphoma who are getting lots of rituximab and so on, even though your measured response will be low because of your immunosuppression, getting your boosters does increase your immunity and does almost certainly reduce your risk of getting severe COVID, and you could get it again,
Yeah.
So in general, I recommend you get it again. Now, the exception might be if someone had an exceptionally severe relapse, of ITP brought on by a vaccine. But in most cases, if a drop does occur of platelets after a vaccine, it's relatively modest and might require some small adjustment and treatment, but not for very long. So, and it doesn't necessarily happen the next time you get the same vaccine or a different vaccine. There's some slight differences between vaccines in terms of, I've forgotten what the results are, but it actually doesn't matter that much because certainly in Ireland, the AstraZeneca is no longer available. All the boosters are, I think they're all the boosters, the older people got the second boosters were Moderna. And I think there's still Pfizer being used for other boosters, and they're the vaccines in use in Ireland at the moment. And of course, it'll change probably. I mean, in the autumn, we might have new Omicron designed vaccines, a variant. It might be the new Pfizer one or the new Moderna one, who knows. But in general, unless someone has had a particularly severe reaction that caused concern, about lasting effects of that, we're recommending people get all their boosters.
Yeah, no, that's fair enough. I suppose my concern is that if it ain't broke, I don't want to run the risk of an ITP relapse brought along by the vaccination when I had COVID and it didn't have any impact on my platelets at all. My platelets were stayed up in the 200, so I had no issue at all,
Right.
But I understand that's the recommendation. Yeah,
and if you're concerned, it is reasonable to get your plate if you're concerned, and particularly if it happened already, get a platelet count done maybe 5 to 7 days after your vaccine, just to see if it has dropped off a bit. But in most cases that we've done that, it hasn't, or it hasn't enough to be of any concern.
Okay, thank you.
Great stuff. Thanks, Bernie. Bonnie, you got your hand up?
Yeah, I was going to go on and talk about the boosters. So I know that at the moment we're allowed to get them if you're over 75, if you've got a compromised immune system or taking drugs like that. But if you're on Eltrombopag or Nplate, what's the thought around us being able to access that booster? Is it an absolute no, or can we get it?
if you have not had steroids or immunosuppressive treatments or splenectomy and recently or splenectomy, then I think technically you're not immunosuppressed. There's probably, I mean, the guidelines are not exhaustive. So at the end of the day, if your hematologist writes an email to the vaccination centre saying this person's immunosuppressed, can you give them a booster? You'll probably get it. But in Ireland anyway, and in the UK now, there may be a different system.
Well, that actually happened in the UK as well, Gerard. Some hematologists did, yeah.
You know, because there's no way anyone's going to write a guideline that covers all the list of all possible combinations of autoimmune conditions and immune suppressant treatments and so on. There are general guidelines, and if your consultant feels you need a booster and writes the message to the right person, you'll probably get it. But I don't think there's any particular, reason if someone's not had immunosuppressive therapy recently, they haven't had steroids in the last 6 months, and they have an intact spleen. I think we'll all be probably getting a second booster maybe this autumn. I think that's probably on the way. So why not wait?
Okay, cool.
Okay, Bonnie?
Yeah, thank you.
Okay. Any other questions? Elizabeth?
I was going to say, it's one advantage to being a geriatric, you get the booster first.
Yeah, but then 3 months later it's wearing off when we get ours, so it swings and roundabouts,
Yeah.
And unfortunately, age is the reason why you're offered it, is that age is the single most, even leaving aside autoimmune conditions and therapy and so on, age is still the single biggest factor in terms of susceptibility to getting severe COVID symptoms.
Yeah. Thanks very much, Gerard. Elizabeth?
I managed with great difficulty because I got IVIG in Australia when I was there for the month of April. I hadn't seen my grandson and he's 2. So this was my goal, to get to Australia. But I managed to contact, but I didn't get so ill at all. I had a very bad headache and I slept. I'm not a great sleeper at the best time, but I slept for Ireland just for a week. And my platelets went up, and as I said earlier, they went back down to 40 then. So I have 1 booster, so I'm free for 3 months. I don't have to think about it. But back in December, when my platelets were about 19, and the month of December was when I went on the Eltrombopag, and I had the 3 at one stage: steroids, IVIG, and Eltrombopag. But it's in the Bon Secours in Cork I attend. And first of all, they were steering me away from the booster, hold back. And then coming up to Christmas, they said, take the booster. It's easier to treat, COVID. It's easier to treat your ITP than to treat you with COVID. But the COVID didn't, seem to be, I got away very easily, really. Just, it didn't seem to, I dread it really. I thought this
was... Well, the thing about COVID, it's very unpredictable. And all these things are just statistical things. The older person, the person with various vulnerabilities and so on, it doesn't mean they're going to inevitably get very sick with it. I mean, we have lots of patients with advanced cancer on treatment, and some of them only tell us when they come back to the clinic, oh, I got COVID last month. I didn't bother telling you because I was fine, And we're kind of, well, did you not think about you might need the Paxlovid? Because there is an oral treatment now for people who are in a high-risk group or immunosuppressed to get COVID. If within 5 days of symptoms, you can get an oral treatment called Paxlovid. Now, it's not suitable for everyone who fits into that group. You have to have adequate renal function, kidney function. And if you're on some other drugs, it would interact. So there's a number of things that have to be checked before you could get it. But we've given it to some of our patients who are immunosuppressed. I'm not talking about ITP patients particularly here, but they might be included if they're on immunosuppressive treatments or have had a lot of, had recent steroids, and that we might consider them for it. But say some of our cancer patients get that treatment, and it does seem to be quite effective, and it's just a tablet twice a day for 5 days. So worth considering if someone is in that immunosuppressed situation and they get COVID.
Yeah, Doctor, I'm a bit blasé towards getting, I've kind of have to hell with COVID. I have bigger problems than COVID because when I told you I had surgery for a blocked celiac artery in September, and my platelets were very good. They were 250, and I had had remission for 5 years from when I got it back in 2013. 2013, 2014, and 2015, and then 5 years. But all after my surgery, and it was big surgery, my platelets stayed steady for about 6 weeks. But I'm blaming COVID for everything. I'm kind of saying that, it was the vaccines and that I would have got over my surgery. This is in my head. I think I'm half in my mind blaming COVID vaccines.
Yeah, I mean, the problem is, of course, that, the never before have so many people received the vaccine, and actually rarely before have so many people got an actual infection. I mean, they estimate that probably 3/4 of the population of Ireland has had COVID, and in fact, there's probably been nearly as many infections as people in that 3/4 of the people in Ireland have had COVID, but a significant number of them had it twice or more. So, and the same with the vaccine. I mean, the vast majority, particularly of older adults, have had their 3 doses. A lower percentage have taken up the second booster, the 4th dose. But, we certainly had in the early days of the vaccine, when it was being given to, say, older groups first, a lot of people coming in with it didn't matter what the complaint was into the emergency department asking, well, is it due to my vaccine? And well, everyone of your age group has had the vaccine, so we don't know is the answer. If everyone has had it, and the number of people turning up in the emergency department with acute problems is no different to usual, then probably it's nothing to do with the vaccine.
Yeah, well, obviously that I got on so well getting through the COVID is that I had the vaccines. I had 2 vaccines.
Yeah, I think we very strongly support that. I mean, one of the reasons that maybe we've got a bit blasé is because, of course, vaccines have protected the vast majority of people against severe disease. I mean, if we had no vaccines, we would be probably in and out of lockdown for another couple of years before it'd be over, and the total number of deaths would be an awful lot higher if we never had vaccines. So I think we can get a bit blasé because we know so many people have had COVID and they've been fine. Anyway, but most of those have been vaccinated.
Thank you, Doctor, and thank you to everybody. It's great because most people don't even know what I'm talking about, this ITP. What's wrong with you?
Thanks very
much. It doesn't change.
It's obvious to be in a support group just because.
Great stuff.
Yeah.
Okay, before I close, Derek and Rhonda, have you got anything you want to say just before I...
Rhonda, would you like to go first? Being the lady.
Rhonda?
Well, I think that it just shows how much people need support. And I think it's really great that you came on and you shared with us so openly everything about, what's happened to you, because by talking about this kind of thing, we learn a lot. And it's really great that you've done that. And I think that it also shows how much these things impact on people mentally and their lifestyle and every day of their life, because, as you say, some people have never heard of it, have no idea. If you say that you've got a blood issue, a blood condition, they just think you've got anemia and you need to take a bit of iron and you'll be fine. And they just do not understand the implication. And then, of course, if you've had a splenectomy, you've got other issues. I have had a splenectomy, and that was 22 years ago. And so, you do have to be careful. And I have to say that I have been very careful during COVID. I don't think that I've been obsessively careful because I didn't think that was the way to go. But I am now going out and doing things, but I am still careful. And I do not like being in very enclosed, crowded places, or even outside crowded places, and I don't go to the theatre except if I know that there are 232 seats left that haven't been sold in the cinema. Then I go along and I'm about 1 of 10 or 1 of 4, as it was in the. So I am still very careful and cautious. And I think that we all should be, not, regardless of what condition you've got, because I think it's only polite to other people, really, respectful and courteous to other people. But yes, I mean, I have written in the platelet about, the mental health implications of having a long-term illness. And I think that is something that we all have to accept and live with and cope with. And mostly we do. But if we have a moment when we're not coping with it, then I think it's really important to talk to people, to seek help. And the more you know, the better equipped you are to cope with everything that's going on. And you can have a dialogue with your doctor because you know enough to be able to talk to them intelligently about what you know and, how you can manage together. Bernie, you were saying that you work really well with your doctor, and I think that's really marvellous because so many people do not have that experience with their GPs or whatever. And so, that was really great to hear. And, we've just got so much out of this tonight, talking together. It's been really lovely. So thank you, everybody.
Thank you.
Thanks so much, Rhonda. Derek?
Thank you.
Well, there's not a lot more you could say after that.
Sorry, I stole your thunder, did I?
Not at all. It gives me the opportunity to put in a plea for plasma donations. That's not something perhaps we should do as ITP sufferers, but plasma is in very short supply at the moment. And I'm not sure what it's like in Ireland, Gerard, but certainly within the UK and Europe, it's pretty dire. So we're trying to persuade people to donate plasma. And if you've got friends who are willing to put their arm out for a wee while and let people extract the plasma, that will be eventually purified and changed into all the necessary things like IVIG and factor VIII hemophilia. It's possibly not known just how long it takes to purify plasma and extract. And you're looking for about 12 months from donation to it being bottled and administered. So if you've got friends who are willing, do persuade them to go and donate the plasma.
What's the age limit? What's the age limit, Derek?
I think it's 70, but it's a little bit airy-fairy at the moment.
Would they take it from me because I've had a splenectomy and all these other things? Would they take it from me?
The short answer is I don't know, Rhonda.
Probably not, I would think. I think when you have, I'm not even sure if someone with ITP in general would be accepted as a donor. Probably not. So it's your friends and relatives who don't have ITP. But the in fact, I think Ireland actually over quite a number of years, because of the whole mad cow disease thing, Irish plasma was not used for the manufacture of products and solvent detergent plasma, but I think that's changing now and it's going to be used. But I don't have the full details on that.
Certainly in the UK, we've just started to collect plasma about 15 months ago, which is a step in the right direction. And the director of that division of the NHS has got big plans, but he's being booted at the backside regularly by somebody we know who say you're not doing enough. Get it moving, get it moving. But he's doing quite well. So we've got to keep on the right side of him as well.
Okay, so I think we probably should wrap it up. I mean, they'd be talking about UK leaders and so on. I wonder how many members of the UK cabinet are still in position while we've been having this meeting. There could be fewer than at the beginning of the meeting. but we'll see anyway.
I'm just hoping by the time I get back to the TV, there'll be a vacancy at number 10, but fingers crossed, we'll see.
Well, the good
I don't
news-
think it'll be long.
I don't think it'll be long, no. If I can just wrap up a few things. I must admit, when we first come online tonight, I thought only a couple of patients. This is going to be a bit tricky with the questions, but, you know, to my mind, it's ended up as being one of the best meetings we've had, you know, with the questions and all that, and, you know, the interaction. So thank you, everybody, for joining in. And as always, thank you, Gerard. Just a quick plug for things coming up later in the year. In September, we've got Awareness Week. And just to let you know that, Gerard, if you've got any ITP nurses or haematology nurses, I'm working on with Louise Taylor, who's the a clinical ITP nurse specialist at Barts in London, and on a nurses, virtual session for an hour and a half, 2 hours on probably the Monday of ITP Awareness Week at the end of September. So when I've got more details, I'll send you them, but it may be worthwhile, you know, to share that with some of your colleagues. So it could be quite good. So on that note, thank you, everyone. Keep a lookout on the website for when all the next meetings are. I'm going to be sorting out some dates shortly. I've got to rearrange the Scotland date because that was due to unforeseen circumstances. We had to postpone that one. But thank you, everyone. Thank you, Gerard, Derek, Rhonda,
Gerard.
Elizabeth,
Thank you
Bonnie,
very much.
and Bernard.
Hello.
Thank you very
Bye-bye.
much,
Thanks a million.
Bye.